Christina Previtt here. I am on faculty with the Modern Management for the Older Adults course. I must tell you, this is a couple times that I've been on this podcast, and I still get butterflies in my stomach before we get started. And so it's like that nervousness before you're doing any sort of public speaking or anything like that, that I'm still getting with this podcast. And I'm hoping that as I continue to be on here every second Wednesday, that it will get better and I will be a little bit less nervous. So this past weekend actually was the first time I was able to go to a live ice course. So I got to see the infamous Jeff Moore in his element, doing some of the cervical spine courses. And it was such a great course. I'm a little biased because I know Jeff, but there's tons of energy, tons of conversations. We had a bunch of different healthcare practitioners. So we had PTs and chiros working together, learning from each other, comparing techniques, and it was a really cool experience. So if you haven't jumped on PT on ACE to see some of their live courses, I think you should definitely do that. And I'm going to make a point out of going to some of the other courses as well in the coming months. So that's really exciting. Okay, so today I thought that we would talk a little bit about mobility limitation in community dwelling older adults. I guess it doesn't just have to be community dwelling. That just tends to be where most of my clients are, in LISTA living in the community. And I was going to talk to you a little bit about what we mean when we say mobility limitation. What kind of are the steps for identifying these individuals? What are the risk factors? And then what are things that we as PTs can do in order to help some of our clients increase some of their functional resiliency, maybe increase some of their functional independence, and give them a little bit of a better quality of life. So you're going to see me kind of popping back and forth with my computer because there was an amazing article that got published in the JAMA, so Journal of the American Medical Association, which one I think is amazing because it was really strongly linking physician referral with physical therapists together and how we need to be talking together about some of our older adults who are either having limitations right now or who are at risk for developing limitations, and trying to identify these individuals, optimize their medical management, and then also make the referral to PT. So I will put the citation for that paper in the comments. The author was Cynthia Brown. She's a physician, and Kelly Flood, who is also a physician. So I thought that was a wonderful kind of plug for PT from some of the medical doctors. Okay, so one of the great quotes that I pulled from this article, which was published in 2014, was that mobility is more than a person's physical ability to walk or move around, and actually encompasses considerations of a person's environment and his or her ability to adapt to it. Like, that is like this perfect sentence which talks about kind of the conceptual framework that we as PTs need to be looking at when we're trying to identify a person's needs in the clinic. We can often have people do a timed up and go, do a short physical performance battery, and they can pass with flying colors until we really start to deep dive into their environment and realize that there are very strong barriers to their ability to navigate, which can be, access to transportation. They have 20 steps to get up to their second floor, and so they're not really going up and down between levels in their home, things like that. And I think Dustin Jones, who does the podcast on the opposite weeks of me, has a really wonderful frame of reference for this, being in home health, because he gets to see both sides. So if you're a home health PT, you probably know this more than I do working in the community about how important it is to not only assess a person's mobility, but start to identify things in their environment that may act as barriers and facilitators to a person's ability to walk around. Okay, so when we're talking about mobility limitation, just like a lot of the clinical geriatric syndromes, we're often talking about this spectrum where we have people on one end of the spectrum that are functioning well, and then we have people at the other end of the spectrum who are in this loss of independence. And so when we talk about mobility limitation, we can sometimes see preclinical mobility limitation or preclinical disability, which we have identified in the past and talked about in terms of, people who aren't saying that they're having trouble navigating around their environment. But if you start to probe a little bit deeper, you're starting to see that they have found compensatory strategies that they use in order to complete the tasks that they wanted to complete. So really prominent example is using a mobility aid or requiring the arms on the chair in order to stand up. They would tell you that they were independent with sit to stand, but when you start to look at how they're performing that action, they are seeing some of these compensatory strategies come in. And it can range from that to a severe mobility restriction where they're having trouble with some of their activities of daily living and self-care. And that is when we'll probably maybe see some of them in home health or in hospital for other health issues, but we're starting to identify those people with big restrictions. Okay, so what are some of the risk factors that we see? So the physicians in this paper did a great job. They kind of scanned the literature, and these were the risk factors that had come up in more than 5 observational studies. And so the risk factors most commonly identified were obviously older age. The older we get, the more these chronic issues can accumulate, and our ability to compensate for them goes down. Low physical activity, obesity, low muscular strength, issues with balance, and having chronic conditions like diabetes or arthritis. So when I read these symptoms, the first thing that popped up into my mind was PT has a role to play in every single one of these factors, except for age. So PTs or rehabilitation professionals as a whole have a huge role to play in trying to increase the functional independence of some of our older clients, which I think is amazing. Some of the other risk factors for mobility limitation that I thought were interesting and are a little bit less prevalent in some of the literature is having cognitive impairment or low mood, depressive symptoms, and being female, that might be a strength deficit thing, recent hospitalization, using alcohol or tobacco, and having feelings of helplessness, which kind of comes into the mental health piece. And as we're starting to see a little bit more literature coming out on social isolation and depression in older adults and how it presents itself in a different way than somebody who is in middle age, I think this is something that we're going to see a little bit more. And so this is kind of that biopsychosocial model where having low mood is probably showing a lack of initiation with mobility, and so that can spiral into a deconditioning cycle that we need to try and break as rehabilitation professionals. Okay, so they kind of further go down. So they say, okay, you have this person in front of you. They may be having some mobility issues. What are screening questions that we can use as PTs or physicians to start talking about mobility limitation? And so if you're coming in, the 2 questions that they said would be the greatest to ask is, do you have difficulty climbing 10 steps or walking a quarter mile, which is 400 meters? And the second question is, because of underlying health or physical reasons, have you modified the way that you do these 2 tasks by either using some sort of aid or even decreasing the frequency at which you perform these tasks, and look for the patient's answer. So if they say no, then counseling on exercise and leading them on their way is okay. If they say yes, then these physicians are saying, we need to start deep diving into it. And what they say is, okay, so they're saying yes, let's do a medical history, see if there's anything that's going on medically, have the physician treat the medical issue, and refer to PT. So the physical examination is going to be around gait, any impairments in strength or lower extremity function, and then going from there and going into a PT assessment, which I thought was amazing. So this is physicians in primary care saying, we are identifying these people with mobility limitations. It doesn't necessarily need to be an orthopedic injury. We're just seeing that they're struggling navigating around their environment, And so what can we do in order to make sure that we are treating these people appropriately? Okay, so in clinic, if we're a physiotherapist coming in, how are we identifying these individuals with mobility issues or mobility limitations other than these screening questions? And the answer is often the short physical performance battery. So I've talked about this in previous podcasts. The reason why this is used is that it's easy to perform. It requires very little equipment, and it kind of does a cursory scan of a couple of different areas of health. And so it has 3 components. Each is scored out of 4 for a total of 12. And one is balance, where people are asked to keep their feet together, or if they can do that independently, go into a tandem stance and try and hold that position for 30 seconds. The other is a 5-time sit to stand test, and then a 4-meter gait speed test, which includes acceleration and deceleration. So the seconds or the time allotted for each point system is a little bit longer than a normal gait speed assessment, just because it's accounting for that acceleration and deceleration. And so often in the literature, if you're looking at mobility limitation, it's anyone with a score under 10 or even under 11. So unless you perform a perfect score, there's something that could be subclinical underneath the surface that may be affecting a person's ability to move around, especially as we get a little bit older. Okay, so now we go into this management question. So we have individuals, their history may or may not be complicated with different chronic conditions. What are we going to do? And just like a lot of the answers, usually exercise is medicine. And so the research to date has shown a combination type of exercise program that often links resistance training and balance training, depending on the impairments of the individual in front of you, is going to be the best way for us to be able to help manage and improve functional outcomes in these individuals. The great thing about this is that you can often link any orthopedic injuries and some of the rehabilitation exercises we're using with some of these larger functional exercises, and they do double duty. They help with both, and so they can improve the person in front of us, their ability to move around their environment. But also we can help to improve some of the strength in our lower joints, and often orthopedic pain can go down as well, depending on obviously the circumstances of the person in front of you. Okay, so there's a lot of different literature. I can send the link, but the exercise group with balance training, the combination of the two has been shown to be superior than either alone for individuals with impairments in balance in order to be able to navigate their environment. Okay, so the other thing that they mentioned, and something that I think that we need to really be thinking about, is if a gait aid is appropriate for an individual. I know that when I was starting as a new grad and people were saying, well, what do I need in terms like, do I need a cane? Do I need a quad cane? Do I need a straight walker? Do I need a rollating walker? That was one of the questions that I was like, I don't know. I don't know which one is going to be best. And so there's a really great table in this paper where it actually goes through all of the different ambulatory devices, say what their support is, the benefits, the drawbacks, and the clinical situations in which it may be most appropriate. So these are those money articles that really give a clinical spin to some of the literature and makes it really useful. So one of the things that they were saying is if we're seeing osteoarthritis in the lower body, which is contributing to mobility limitations, the straight cane may be one of the most appropriate because it does help with some assistance in balance and proprioception and reduce weight bearing on the opposite side. So if we have a unilateral arthritis, it may not provide enough support though, and people can't use it as a way to take a break like a rollator would, where you can have somebody sit if they really need to, if some of their endurance or cardiopulmonary system is just not doing well and they need to take frequent breaks. And then so sometimes it can be difficult that way. But one of the ways where it's indicated is in osteoarthritis or any peripheral neuropathy in the lower body. The other one that I want to talk about was the pickup walker. So it's super stable, but it doesn't have that same rolling. So you have to have a certain amount of strength to be able to lift the walker and keep keep pushing it forward. So you have to keep doing that upper extremity lift. So it requires a little bit more strength and coordination, which can be the drawback to using a standard pickup walker. Clinical situations which can lead to mobility issue is around hip fracture, and if there's any non-weight bearing that's needed, or a unilateral amputation prior to prosthesis. So those are the two they kind of talked about. And then it goes all the way down. So we can talk about the rollating walker too. We use that a lot in PT. Sometimes there is a really neat argument around chicken or the egg. If we're trying to give advancing mobility aids, are we actually discouraging people from navigating around their environment? But that is for a different podcast. I think that's a really cool debate to get into. But some of the benefits of the rollating walker is that it allows people to feel more steady on their feet. They have a faster gait pattern than they do with a standard walker or with independent ambulation if they are having a fear of falling, or they feel like they just don't have the same power and drive out of their lower body. And it turns a lot easier than other mobility aids do, other than obviously the cane. There's brakes, and it can be kind of cumbersome to move around depending on the style. And they can get expensive too for some of our older clients who just don't have some of the funds. So there are some programs in the community across different states and provinces that can help people who are having issues paying for some of these mobility aids. But it's definitely indicated for anybody with cardiopulmonary diseases where endurance is an issue, and any balance or coordination deficits that we see in terms of optimizing safety for people as they navigate around their environment. So I will send a link for this. So bottom line, we need to start screening some of our individuals coming into the clinic and starting to talk to some of our physicians in town about screening for mobility limitation and identifying these individuals before they have gotten to a point where independence is at risk, or they've lost their ability to take care of themselves and are requiring future either institutionalization, increased help from spouse or family members. And if we can identify these individuals early, often we can have a huge benefit, and we can see a lot of improvement in a relatively short amount of time. If we are identifying these people, and if they are medically stable, or referral to PT or rehab is warranted and recommended for primary care physicians, which I think is amazing. It's a huge step forward for linking us together. They also recommend that PTs send updates back to the physicians so that they can be on the same course and the same level when it comes to person's functional abilities. And after the assessment, often if there's a balance impairment, then the combination of exercise with the strength training component and balance training, retraining with whatever modality you have available for you at the clinic is going to be the most appropriate. And then finally, identifying environmental barriers and applying gait aid as appropriate is going to help with increasing functional independence until we get to a point, hopefully, fingers crossed, that we can kind of DC any of the gait aids that we see. All right, I think that is it for today. I'm getting better at rambling for more than 15 minutes, so I'm gonna have to make sure that I keep a watch and I don't go too far or too long. But next week, every Wednesday, we do the older adult content, so you should definitely bookmark it. Next week, we have Dustin on deck, and we will see you then. Bye, guys.